to say. So I begin now. So we have before us our witness, Dr. Patricia Houston, Vice Dean, Medical Education, Temerity Faculty of Medicine. Ms. Houston, you have 5 minutes. Dr. Houston, you have 5 minutes for your opening remarks.
Thank you very much for inviting me here today, Madam Chairperson. First and foremost, I would like to apologize for the internal miscommunication that occurred at Temerity Medicine that caused some delay in my appearance. It is certainly an honor for me to be here today in order to answer your questions and to speak about medical education and how it contributes to Canada's healthcare system. As you have stated, my name is Dr. Patricia Houston. I'm a practicing anesthesiologist and critical care physician, and I have done this for over 40 years. I currently practice at St. Michael's Hospital in Toronto. But I have also had many leadership roles over the course of my career. And currently, as of 2020, I am appointed as the Vice Dean of Medical Education at the University of Toronto's Temerity Faculty of Medicine, where I'm a full professor. In this role, I am responsible for the MD program, postgraduate medical education programs, continuing professional development programs, the Office of Learner Affairs, our Integrated Physician Scientist Training Program, and most recently, I took on the oversight of our expansion to our Scarborough campus. Madam Chairperson, this study topic is important. All Canadians want a healthcare system that has the capacity and the resilience to meet the needs of our patients, our families, and our communities. The University of Toronto has a long history of leadership in medical education. We are the largest single contributor to practicing physicians, representing over 20% of newly trained Canadian doctors who graduated into practice in 2024. Medical education is a long, complicated, and complex process, so with your indulgence, I would like to outline the journey very quickly. I apologize in advance to my physician colleagues who are a member of this committee and are very familiar with this, but I think it is important context. After completing an MD program, whether it be at U of T, a Canadian medical school, or an international medical school, all learners must go on to the second part of their education, which is postgraduate training, which most people know as medical residency. And the reason it's called a residency is in the very old days, even before my time, these trainees actually lived in the hospital and thus were called residents. Residency training can range from 2 years for family medicine to over 70 years for programs such as neurosurgery. The number of provincially funded residency positions is determined by the province in collaboration with the educational institutions and our healthcare partners. Temerity Medicine trains physicians across more than 80 accredited postgraduate specialty, subspecialty, and family medicine programs. Our family medicine program is one of the largest in the world. In 2024, 32% of newly graduated family doctors who trained in Ontario and went into practice in Ontario graduated from the University of Toronto. We also have internationally trained physicians who enter the health workforce in Canada through one of 3 pathways. International medical graduates, the IMGs, who have Canadian citizenship or permanent resident status. These learners have gone abroad to complete medical school, and they return home to complete their residency requirements. They must go through the CARMS R1 PGY1 match process, and they are eligible for our publicly funded residency positions across Canada. Second, there are internationally trained physicians who are fully certified to practice. They have completed both undergraduate and postgraduate education, and if they satisfy immigration and licensing requirements to practice, they enter practice in Canada. And third, and I think this is what you want to speak about today, are internationally funded trainees. Canada is known around the world for its high-caliber medical education system. And by design, we have created spaces for internationally trained doctors who are funded to come to Canada temporarily to train and then return home. And most are funded by governments or institutions. and we train both residents and fellows. So these are who go on to subspecialty, very specialized training after their residency. We at Temerity Medicine are proud to serve Canadians and the Canadian healthcare system, and I welcome any questions that you might have about the work that we do.
Very much. I now go to the question and answer segment. The first is a 6-minute round. It means that every question and answer must be done within 6 minutes. And once again, I will give the questioner and the answerer the opportunity to be as precise and as concise as you can so we can get enough questions in. So I begin for the Conservatives with Mr. Mazier for 6 minutes, please.
Thank you, Chair, and welcome, Dr. Houston. Dr. Houston, how many foreign doctors did the University of Toronto train last year through the Visa Trainee Program?
So last year, in total, we had 459 physicians in this program,
Trainee Program.
in
Okay.
the residency program
Thank you.
and the fellowship program. So total residency and fellowship.
How many returned to their home country after training?
They are all expected to return to their home country. It is part of the contract that we have with their sponsor that the trainee also signs on to.
How many visa trainees completed their training at the University of Toronto last year?
I don't have that exact number, but I can provide it to you because they range from PGY 1s to PGY 7s. We accept between 2 and 4 residents into family medicine, and they return after 2 years. Those in the Royal College specialty and subspecialties train for a variable number of years depending on the residency program.
So would, like, you have a rough idea, like 1,000, 500?
Oh, no, not that large. So if we have 459 in the program, the maximum we could send out in any given year would be 459.
Okay, if you could forward that information, that'd be
I will
great.
certainly give you the information as to how many graduated last year.
Okay, and then how many Canadian medical students graduated from the University of Toronto last year?
So the current cohort is 303 students that came in, and last year I believe we graduated 259 students. And the reason for the discrepancy is that we have expanded our medical school numbers, our cohort, in the last years due to
Okay.
increased funding.
Yep, I got my number. Thank you so much. How much does a single Saudi-sponsored visa trainee pay to the University of Toronto per year of training?
The trainee does not pay the University of Toronto any dollars. The sponsor pays us $100,000. They also provide the salary and the cost of living for accommodations for the trainee.
So the sponsor would be the Saudi Arabian government?
It's either the government or there are individual institutions in Saudi Arabia or the other 5 Middle Eastern countries that send these funded trainees.
And how, you have any idea how much the total amount is?
The total amount that comes into the University of Toronto? Well, our usual number is between 450 and 500 trainees per year. So if you do the math, that's between $45 and $50 million.
Wow.
It is a significant amount of money that provides funding for our education and research programs.
So $100,000 per student and
Per year.
per year. And then, what was the numbers again? 400?
We have, as I told you, so last year we had 459, and we usually have between 450 and 500 of these learners.
Does the money that the University of Toronto collects from foreign-funded visa trainees go into the faculty's general revenue? Yes or no?
Yes and no. I'm
Okay.
happy to expand on that.
Yep.
So the money first comes into the postgraduate medical education office.
How much?
All of the money.
Percentage?
All of the money initially comes into the postgraduate medical education program. We then determine how much money is needed to support the education programs, both centrally in the postgraduate medical education office and across the medical education program centrally.
so
and then
those-
we distribute the money to the departments, and subsequent to that, we send whatever money is still remaining to the dean's office for use to support other education and research activities.
So it goes into general revenue first, and then you decide where it's going to go,
It comes to
after
the
that.
postgraduate medical education office first.
which is considered general revenue.
For the postgraduate medical education office.
Okay, and you can table all that information?
I am happy to provide you with that information.
Okay. Is there anything requiring the University of Toronto to use foreign visa trainee funding to expand medical training for Canadians?
No,
No?
no, no. The funding for the expansion of programs for Canadians is provided from the Ministry of Health or MCures.
I
It doesn't go directly to the expansion of the programs. It supports all of the programs.
So it goes
The
into
existing-
general revenues, and you decide where it goes, and it doesn't go back into funding programs?
It supports
1
all
minute.
of the programs, not just specifically the expansion programs.
So it
It
could,
is also used,
it
so I'll
could
give
go-
you an example. It is also used to support our Office of Learner
but
Affairs.
who would, like, it could go into artwork for the walls. Like, it could go into anything into the
We
university.
take responsibility for the use of the funds, and I would be happy to provide you with what the
Yes, that would
expenses
be
are
very good.
within
You could-
education.
If you could table with the committee what fund visa trainee revenues
30
and where they're
seconds.
deposited, that'd be great. How much money in total did the University of Toronto receive last year from foreign governments to train visa trainee doctors?
Amount of dollars that I just explained to you, the $45 million approximately for the 459 trainees we had last year.
Before accepting the money from foreign governments, do you evaluate that country's human rights record?
We do not. In the postgraduate medical education office, that is not our role.
Thank you. I think your time is up.
Thank you, Chair.
I now go to the Liberals. Mr. Elfson, for 6 minutes, please. Doug? Turn on your mic.
Apologies. Can you hear me now? Yes. Thank you. Thank you,
Loud
Dr.
and clear.
Houston. Yes, good. Thank you, Dr. Houston. Thank you for coming out here. So these visa trainees we're talking about, I just want to confirm this was part of your testimony, but I just want to get this, so that there's no confusion. These are funded by the governments that send these people, and these are not funded by provincial or public funds. Is that correct?
That is correct.
All right, thank you. There have been, there may have been a misunderstanding as well regarding whether these trainees are taking residency positions from physicians who are eligible to practice in Canada. Does that happen?
It does not.
All right. Thank you. And you said that it is the province that is determining how many medical residency spots that you have.
That is correct. Each year, the Ministry of Health determines how many residency positions there are across the institutions in Ontario. It used to be 6, it is now 7. And we work with the ministry to determine in which of the programs, family medicine and the Royal College specialties, they would like those spots attributed to. We then work at the university with the departments to ensure that we have the numbers in collaboration with the Ministry of Health. And then we put those numbers into the CARM system. And every year at the University of Toronto, we have the good fortune of filling all of our positions. And just to give you some context, we have, through the CARMS match, we match to 183 family medicine spots and 276 Royal College spots for a total of 459 residents that go through the PGY1 match. We have a total of Ministry of Health funded residents of 1,865 spots.
All right, thank you. Now, this funding you receive for the visa trainees, you said it goes to support the postgraduate programs. Could you expand on that as to what kind of things that this money helps support in the postgraduate programs?
It is first used at postgraduate medical education to essentially provide the funding for all of the administrative structures within postgraduate medical education. That is the outreach programs, the admissions process, the registration process, because all of our learners must be registered with the College of Physicians and Surgeons of Ontario, our curriculum office that develops and helps to support curriculum, our accreditation office, our student and learner assessment office, and all of the supports for our learners that we have available through our learner affairs office, which includes supports for learner wellness.
Thank you. So is it fair to say that this funding that these governments provide for these visa trainees helps to support all of the residents in your programs?
That would be very true, yes. And I think that when we think about these visa trainees, not only are they supporting education, but they are essential at this time to the healthcare that is delivered across our hospitals in our Toronto Academic Health Science Network.
All right, thank you. What would be the effect on your postgraduate programs at the University of Toronto if this program were to be canceled and this funding were to suddenly disappear?
It would be a difficult situation. We faced this in 2018 when some of the Saudi learners left us and where we had reduced number of Saudi learners for a number of years. We do have the reserves and the capacity to manage. It would be difficult. We would also have to work with our hospital partners to ensure that there were enough healthcare professionals to backfill for the healthcare needs that were previously filled by these visa trainees.
Thank you. Having gone through a Royal College residency myself, as I believe Dr. Strauss across the way has, I'm very familiar with, the workloads at night, sometimes having to be in literally two places at once. And when you don't have enough staff, of course, we've seen the outcomes where you don't have enough people to manage the problems. Are these trainees contributing to patient care and patient safety in the hospitals?
They absolutely are. They also contribute to the education of the more junior residents and the medical students and the other health professional learners in our environment.
All right, thank you. Our latest budget, 2025, from the federal government, involves some increased investments for increasing international talent. Can you very briefly describe whether there's any strategy to take advantage of this funding?
30 seconds.
Absolutely. Our president is very committed to working with the federal government. This is a huge opportunity, not just for the University of Toronto, but all of Canada to attract career scientists, postdoctoral fellows, and doctoral fellows to actually come to Canada and improve our ability to meet the needs of our communities for the future.
Thank you.
That particular session. I'm going to go to Madame Larouche. Madame Larouche from the Bloc Québécois. 6 minutes.
Yes, 6 minutes. Yes, thank you very much, Madam Chair. Dr. Houston, can you hear on the English? Madam Chair, was somebody able to explain to the witness before committee started how to use the console? Can you hear us? Can you hear me now? May I start my 6 minutes over again, please? Because that was a technical problem. I will start again.
Merci beaucoup.
Thank you very much. So I will begin again. Dr. Houston, earlier you talked about the 2018 incidents or what happened during 2018 earlier. So you said you lost about 800 residents or so in 2018 because there were diplomatic differences in 2018-2019 between Canada and Saudi Arabia, and that really threatened some of the program. As you said, 800 or so residents lost. The Journal of Medical Associations wrote at the time that a symbiotic relationship, that's what it started as, has evolved into a paradox because now there are problems in matching students, and then our system is vulnerable to the spontaneous decisions of a foreign government. That's what happened in 2018, 2019. That's something that was very important, that was written in the Journal of the Canadian Medical Association, and you mentioned yourself that you lost people in 2018, and when we find out why, that's very concerning, that diplomatic differences can really impact us so much.
For the question, and it was you mentioned the number 800. It was a significantly lower number than that because, again, it is not just Saudi Arabia, but we have learners that come from Kuwait, the UAE, Bahrain, Oman, and Qatar. So it was a much smaller number of learners that left, and most of them have returned. 2018 was a wake-up call for all of us. We recognized at that time the vulnerability of relying on this funding, and we have since ensured that as needed and when needed, we will be able to continue to support our education and academic programs. And as well, what we do have, should there be more provincial funding, we have the capacity at this time and into the future to increase the number of residency positions that we could fill if funded by our provincial government.
D'accord. Donc, juste pour bien suivre,
All right. So to make sure I understood it correctly, you gave us numbers earlier of what these students bring. So your faculty has agreements with a number of countries, including Kuwait, Saudi Arabia, UAE, and so on. We can talk about it later, but there are not countries necessarily that are associated with good human rights violations. So what's the percentage of these countries? Do you have it with you? What percentage of your overall faculty this represents?
We have from these countries, approximately 40% are from Saudi Arabia, 30% from Kuwait, 20% from the UAE, and the remaining from the 3 other countries.
ma question était plutôt
My question was more the percentage of the budget that represents in your residence program. What percentage of your residency program budget comes from these countries? Would you have it in percentage?
I didn't get the question.
Not working?
Was previously, I didn't get that question.
All right, okay. I will suspend while we check out what's going on here.
Would you have it in percentage?
Yes, it's approximately 8%.
C'est vrai que c'est quand même un chiffre élevé.
Yeah, that's still a high number, but do you consider that it's healthy for a Canadian university to depend on money from these countries to fund its programs? Because 8% is still a good proportion. Do you think it's healthy to be so dependent on them?
As I stated previously, we understand the vulnerability, but should this funding cease, we would be prepared to manage at that time.
Parce qu'on n'est pas à l'abri d'un soubresaut, d'une saute d'humeur d'un de ces pays.
Because, we're not protected from any change of mind or different opinion from one of these 5 countries. As you said earlier during an answer to a different colleague, that you're not responsible for looking at human rights issues, but there are criticisms of some of these regimes. Does the University of Toronto look at the ethical side of things before concluding these agreements?
The University of Toronto has a very diverse environment, and we are committed to working with our global partners. It is an opportunity for us through training these physicians that go home to their home countries to take back with them the values that we instill through our programs.
47 seconds.
Donc, je vais juste lire parce que...
So I will just read here what I have, because we see that in a blog post by the Association of Medical Professionals. There is an inappropriate side to really depending on funding from pharmaceutical companies and foreign countries and so on. That's their opinion, and there is a great reliance on that kind of funding, and I will come back to this during a later turn.
Thank you.
Merci.
This is a 5-minute round, and I will do the same thing, try to give you time to round out your questions and answers. So we begin with the second round for the Conservatives. Mr. Strauss.
Chair, Dr. Houston, do you know how much money came to postgraduate medical education at the University of Toronto, specifically from Saudi Arabian sources last year?
Well, if we say that Saudi Arabia represents approximately 40% of the learners, and we got $45 million, then I would say it would be $18 million.
Well done. Fast math. Thank you. Does the University of Toronto receive, and particularly the Temerity School of Medicine, receive other sources of funding from Saudi Arabia other than that, like, let's say in terms of donations or other partnership, let's say not directly associated with the visa trainees?
Not to the best of my knowledge.
Okay. You mentioned this episode in 2018. I was on a medical faculty at that time. I remember it very well. Just to say it into the record again, Chrystia Freeland was then the Foreign Affairs Minister. She criticized the Saudi government. They were putting women in prison because they had the temerity to advocate for their right to drive. And from my recollections, medical faculties lobbied the Foreign Global Affairs Canada and Chrystia Freeland, who happens to be the Member of Parliament, I believe, for most of the University of Toronto Medical School, to temper her criticism, let's say. Are you aware that officials at University of Toronto lobbied Global Affairs Canada or the Minister of Foreign Affairs to temper her criticism of Saudi Arabia in order to protect this funding?
I am not aware of that occurring.
Okay. We've spoken a lot about the difference between, let's say, funding and capacity. It seems to me pretty obvious that if the University of Toronto currently has the capacity to train Saudis, but the funding is coming from Saudi Arabia, if some other source were to provide that funding and Saudi Arabians were, or the government of Saudi Arabia was not given those residency spots, like if that funding was restored from some other source, the University of Toronto could, for instance, train Canadian IMGs who want to come back home?
We have the capacity at this time and have put forward to the provincial government a further expansion plan for our residency program. So the short answer is yes, we could further expand the number of residents that we graduate in any given year.
And then an association who represents these Canadian graduates from Ireland, or Irish, Australian, UK, American, Caribbean schools said that often these folks will drum up their own funding, but this funding is not accepted by faculties of medicine. Does your faculty have a policy about this? So if I have an Irish medical degree and my hometown of St. Thomas, Ontario says they will fund my residency, would you accept those funds the way you accept funds from the Kingdom of Saudi Arabia?
That is not allowed by the provincial government. The provincial government, for both the MD program and the postgraduate medical education programs, sets the total number of domestic spots available.
I see. The Kingdom of Saudi Arabia is a brutally repressive dictatorship. So shortly after this episode in 2018, they lured a Washington Post journalist into their Turkish consulate. They dismembered him with a bone saw. This repression continues to this day. They executed somebody for tweets critical of the government this past summer. Do you have any concern that the Temerity medical faculty is compromised by receiving money from this sort of source? Do you think that the faculty, for instance, is able to condemn these practices in Saudi Arabia, or would that risk their funding?
It is not my role. I do not take a role in the political arena. I do take a role in ensuring that we support the education of these trainees that come to us.
I'm going to interrupt you for a second there. So the Temerity Faculty of Medicine does not have a view as to whether women should be allowed to drive?
May I say that may be off the topic about their view on whether women should be allowed to drive?
Well, I think it's directly on topic.
Go ahead. You have 1 minute left.
The Temerity Faculty of Medicine would not put forward a view on that.
Okay. So Women's College Hospital is part of the Temerity Faculty of Medicine? Like, it doesn't view itself as a feminist institution that promotes equal rights for women both in Canada and abroad?
Women's College is one of the Tasman hospitals.
And it doesn't take a view about women's rights globally?
I have not recently reviewed any of their whatever they have put out about
Okay,
this.
I have one last question. We received an email from a member of the University of Toronto Medical
16
Faculty
seconds.
who wishes to remain anonymous because of fear of reprisals from the administration. He says the impression of rank-and-file faculty is that the Saudi money is used to prop up the growing administrative structure and roles at the faculty rather than improving the training quality and experience of Canadian learners. Is there a reason you can think of why he would want to remain anonymous for fear of reprisal?
The shortest answer possible.
I cannot.
We now go to the Liberals, the second round. For 5 minutes, please. Ms. Sidhu.
Thank you, Madam Chair. Dr. Houston, my question is about the shortage. We continue to hear many specialties face persistent workforce shortage that impact on wait times, service access. The committee has heard from other witnesses that internationally sponsored help address healthcare workforce shortage. Can you expand on that?
Could you ask your question again?
Some specialties shortage. And it's also persistent workforce shortage, also impact on wait times in the hospitals and service access that also impact on the service access. So can you expand on this, how this internationally sponsored help address this healthcare workforce shortage?
Well, they do provide, they absolutely do provide significant service in the hospitals to our patients and to the healthcare system. So yes, at this time, each of those residents that's working in our system is contributing up to 50 or more hours per week of work that would otherwise have to be done. And at this time, we have a crisis in human health resource. So it would not be easy to backfill that. And that is why we all must be looking at how we increase the number of healthcare professionals, not just doctors, but healthcare professionals, to meet the needs of our communities.
Dr. Houston, you did talk about IMGs. One in three IMGs are Canadian citizens or permanent residents returning home after studying abroad. How can federal and provincial partners better support these Canadians who want to complete their residency training here? And also you said you put the further expansion plan put forward to the province. Can you expand on that?
Certainly. Well, those IMGs, they are referred, those are Canadians and permanent residents are referred to as Canadians who study abroad, are eligible to go through the IMG stream and match in the first iteration of the CARMS matching system, and then again in an unblended way to go through the second match of the CARMS matching system. And so the way to increase their access to residency positions is to increase the number of residency positions. We have put forward to the government, we were given an additional 67 postgraduate medical residency positions in the expansion that occurred, and we could certainly take many more.
The other thing is I just want to highlight Budget 2025 introduced $5 billion health infrastructure fund, including support for hospitals and medical schools. How could this investment help expand training capacity and support the learning environment for the future physicians?
Well, I think they can be used to build medical schools, and I laud our provincial government for the 2 new medical schools in Ontario, both at TMU and at York. They can be used to refurbish our medical schools, that some of which have not had their physical structures addressed in decades. They can be used to build new hospitals, and they can be used to build new research labs, because we can't just do the education, we must be doing the research and innovative work as well, in order to not just increase the number of healthcare workers, but to improve the healthcare system.
Thank you. Madam Chair, do I have more time?
You have 1 minute, 36 seconds. I'll give you a 1 minute call out in a 30 seconds.
I also want to say that Budget 2025 includes significant investment to attract international talent to Canada, including to support recruitment of international doctoral students and postdoctoral fellows. And new support for universities, you talked about the TMU. I'm very pleased TMU in Brampton is getting $25 million. But definitely, how the Faculty of Medicine planning to take advantage for the specialties, like some special doctors, because surgery is not happening because there's a shortage. So on the specialty side.
So the funding, as I understand it, is to recruit scientists more than to, but many of those scientists are clinician scientists. So certainly as we look to who we recruit, it should be for those areas of science where we can best support them and where they are needed, and that often aligns with the clinical needs as well. As well, we would be able to recruit postdoctoral and doctoral learners and fellows, and again contribute to the rich science that is done by the University of Toronto and by Temerity Medicine, which has led to us being ranked in the top 10 in the world.
Thank you. I will pass on.
Thank you. That's good. And I'll go to Madame Larouche. 2 minutes et demi.
2 minutes and a half. Thank you, Madam Chair. Dr. Houston, I quickly want to come back to the issue of human rights. Just recently, the Prime Minister, in order to conclude a deal with Saudi Arabia, stated that there was no longer, that his international policy was no longer feminist because he didn't want to bother Saudi Arabia. Do you know the number of the percentages of residents from Saudi Arabia and other countries that you have agreements with? Do you know how many are women or what percentage are women?
I do not have that number, but I would be happy to provide it to you.
Parfait.
Perfect. You also mentioned, actually, what I'm interested in is you talked about a few percentages and other funding for the university. Is your faculty ready to convert some of those positions that are for IMGs or ITPs rather, to others for Canadians, for example?
Absolutely. We are ready and able to expand our capacity. We are expanding to Scarborough, which is an underserviced area, and we have recently expanded to the Simcoe-Muskoka region with the opening of 2 family medicine teaching units, one in Orillia and one in Midland, and they have capacity to expand even further.
Qu'est-ce que ça vous prendrait pour arriver à être...
What would you need to get to be able to complete that, to be less dependent on foreign programs?
Well, as we expand our programs with provincially funded learners, we will absolutely be creating those physicians and healthcare providers to serve the province of Ontario. They will not bring in the tuition, $100,000 a year, that the internationally funded students do bring to us. So there would be a difference in the funding to the University of Toronto if all of those positions were replaced by Canadians and permanent residents.
I go to Mr. Bailey for the Conservatives. 5 minutes, please.
Dr. Houston, through the chair, the University of Toronto's mission statement reads, quote, "The University of Toronto is dedicated to fostering an academic community in which the learning and scholarship of every member may flourish, with vigilant protection for individual human rights and a resolute commitment to the principles of equal opportunity, equity, and justice." Do you think the Kingdom of Saudi Arabia shares these values?
Comment on that.
I'm sorry?
I haven't looked at the mission statement of the Kingdom of Saudi Arabia.
No, that's your university mission statement.
I
that just read.
understand that.
Yeah.
I'm very supportive of our mission statement.
Okay.
And our mission, as part of our mission, we work with multiple partners around the globe.
Okay. Will you condemn the human rights abuses committed by the countries you've received funding from? Yes or no?
I choose not to respond.
All right. I will take that answer. Do you personally...
I don't see that that is something that I need to answer to.
I want you to know that you've really given us great answers. We've had a whole bunch of witnesses, and I really appreciate the information you've been giving us. What I am trying to determine is, if a Saudi Arabian person can take that spot, what does it take for us to get an IMG in that same spot? Is it $100,000?
No,
So
it's provincial funding.
I realize that. But
So it's
when
not
we
the
see this budget,
$100,000?
when we see this budget that has just been set out, how many extra spots are we going to create across Canada? And I'm thinking, well, 97 million could possibly create 1,000 more medical special graduates if we use the money correctly. So some of my questions are trying to get to that answer. Are we using this money correctly? And I'll ask you this question. You'd mentioned that you have all these spots. Now, I'm going to call the Saudi ones extras, and we're going to call the ones that you currently have medical students for as domestic spots.
Correct. So I call them domestic and supernumerary.
How can we increase those domestic spots? What type of dollar figure do we need to have? And I understand you want it to be provincial, but if you could just indicate to me a dollar figure per year per student for a resident on a 5-year program, not family medicine, a specialist. Is it 100,000? Is it 50,000? Is there a number?
Yes, there is a number. So let's start with medical school, because you can't have a resident unless you put a student through medical school. So it costs approximately $80,000 a year to put a medical student through the MD program per year, one student, 1 year, at the University of Toronto. And the reason why the tuition for the postgraduate medical education programs is $100,000 for the Middle Eastern countries is because that's approximately the cost to support that residency position.
Thank you. Now, other universities that I have spoken with have received donations. You'd indicated that the University of Toronto has not received any donations towards any expansions or anything from the Saudi government, just $100,000 per student. There's been no extra kindness.
I said to the best of my knowledge, I was not aware of any other donations from the Saudis to the Temerity Faculty of Medicine. And these are not donations. This is tuition that they pay.
Thank you. These IMGs that we have in Ireland, I feel really bad for. Now, I'm from Alberta. We've got 44 students that want to come back to Alberta and do the CARMS match. They're not having any success. They're finding difficulty. The Alberta government is now looking at creating spaces, and I guess they will associate a number to increase those IMGs. What would it take for
47 seconds?
your university to increase spots?
Would take first the province saying that they would support the expansion, and then the funding from the province for those spots.
Thank you.
30 seconds?
Do you have any concerns about the Canadian university's dependence on the visa trainees from Saudi Arabia, a theocratic monarchy alleged to have committed human rights violations, including state-sanctioned murders, oppression of women, minorities, and curbing freedoms daily?
The
13
University
seconds?
of Toronto trains those physicians to take the values of the Canadian healthcare system and our university back to improve their healthcare system.
Thank you very much. I now go to Ms. Chi for the Liberals. 5 minutes, please.
Thank you, Chair, and thank you, Dr. Houston, for appearing today. And Dr. Houston, just for the record, who determines the number of public-funded residency positions and their allocation?
Ministry of Health for the province of Ontario.
And what does that process usually look like? Each year, you go to the province with a number of spots, and can you outline those?
Sure,
steps
I'd be
for us?
happy to take you through the process. So the first thing we do is that we meet with the Ministry of Health. So I'm going to speak specifically to the University of Toronto. We meet with the Ministry of Health, and they tell us through a transfer payment agreement how many residency positions, and this is the total number of positions. So from PGY1 to PGY7, they will support for the upcoming academic year, and they also give us direction as to how they want those spots distributed. First and foremost, between family medicine and the Royal College spots, and then their preference as to which Royal College specialties should increase in number or at sometimes decrease in number. We then take that information back. We have a committee where we ask every program to send to the committee their capacity for the upcoming academic year, and usually their capacity is more than the number of spots that we have funded. We then sit down at a subcommittee of our Postgraduate Medical Education Advisory Committee, and this committee is called the Allocation Committee, and collaboratively we decide on this many spots, to family medicine, this many spots to Royal College, and how many across the different specialties. We come to consensus and agreement. We send it back to the Ministry of Health for their approval, and then we go forward with our plan and we submit it to CARMS for the next year.
Thank you, Dr. Houston. And on the expansion, because you mentioned UTSC
Yes.
for the medical school, how many spots, additional spots, does it provide?
So we got in that expansion, we got 44 new MD spots in addition to our base of 259 spots. We got 67 postgraduate spots, 40 in family medicine, and only 27 in the Royal College spots. And the 27 of those, actually 12, were taken away in a prior iteration of an adjustment of residency spots. So actually, it was only truly a 15 in addition to where we had previously had in postgraduate Royal College spots. And that is why I'm saying for a program as large as ours, we have capacity to further expand.
Right. And just, I want to kind of dwell on the UTSC piece because that
Sure, I'm
area-
happy to talk about
Yeah, as
Scarborough.
you know, it's Scarborough, the east end of the city is very underserved.
One of the worst in Ontario.
Yeah, and do you find that the graduation rate from the UTSC campus will help with the capacity in the region?
That is our hope. So we have the 44 spots are in place. It was just this year that we went up to the total of 44, and we will not be opening the Scarborough campus for the MD program until the fall of the 2027 because the building isn't open. But our experience in our prior expansion to UTM, when we expanded by 54 spots in 2010, was that they stay. So this has also been borne out by the work that's been done by NOSM. If you train them in a community, many of the medical students, postgraduate trainees, go on to stay in the community. And another example of that is the Family Medicine Teaching Unit that we opened in Barrie at Royal Victoria Hospital in 2009, and most of their graduates have stayed in that community, again, which is an underserviced community.
Yeah, thank you so much. I will share my time with Dr. Jazik.
1 minute.
Thank you so much, Madam Chair, and through you to Dr. Houston. I've just come to this committee from Science and Research, and of course, as you noted and has been discussed, our budget 2025 is looking to attract international expertise to come back, particularly on the research side. And you mentioned specifically doctoral, postdoctoral fellows potentially being part of that attraction back to Canada or to Canada. Are there specific areas of specialty in terms of the type of medical assistance that is crucially needed, perhaps, at this point?
3 seconds.
Well, I think that we need to do work in the neurosciences. I think Alzheimer's and neurodegenerative neurocognitive disorders is of particular concern with our aging population. We have a strength in this in Toronto through our Toronto Academic Health Sciences Network. Cardiovascular disease and cancer, of course, will always be something that we have a burden of. And I think really looking at health systems, looking at not just who the doctors are and what the research is, but the research around how to make a better healthcare system is something that we have to explore.
Thank you very much. I now suspend the meeting for the next hour.
Chair.
Now, once again, we have witnesses present in the room. We have Ms. Amber McPherson, who is an emergency medicine physician. We have Dr. Marie Dagenet from the National Dental Examining Board of Canada. And we have Dr. Meredith Irwin, Pediatrician-in-Chief, the Department of Pediatric Sick Kids Hospital. So I will just run over the process quickly. You have each 5 minutes to present. I will give you a 1-minute yell and a 30-second yell so you can wrap up. If you can't finish what you needed to say, it will actually hopefully come out when you're getting the question and answer sessions. So I will now begin with your opening remarks. I will begin with Dr. Amber McPherson. 5 minutes, please.
Thank you, Madam Chair and members of the committee. My name is Amber McPherson. I'm a U.S. trained, board certified emergency medicine physician with 12 years of experience prior to moving to Ontario earlier this year. I came to Canada because I was increasingly frustrated practicing in a system where patients are routinely bankrupted by life-saving or even routine medical care. I wanted to work in a country where access to basic health care is a right, not a privilege. I'm not alone. Many U.S. trained physicians feel this way, especially recently. A growing number of American physicians are seeking to leave a system where evidence-based medicine is becoming increasingly politicized. We want to practice in countries where science, equity, and public health are supported not only by professional organizations but by government policy. Canada, as our nearest neighbor, is a natural first choice. Unfortunately, Canada's licensing and immigration processes are so burdensome, disorganized, and inconsistent that many physicians give up before even arriving. In my own case, I spent months in back and forth communications with British Columbia's licensing bodies trying to determine whether I qualified for a license. I had connections on Vancouver Island and a likely job offer, but the answers I received were inconsistent and ultimately inconclusive. I eventually shifted my attention to Ontario, where I was finally able to obtain my certificate to practice. Once licensed, I was able to secure a job almost immediately, and I chose to join the Waterloo Regional Health Network, where I am happy practicing today. Like any immigrant, I hope to obtain permanent residency to reduce long-term uncertainty and build a stable future in Canada. But the pathway is far from straightforward. For example, Ontario has a provincial nominee program with a specific stream for physicians, yet the program currently excludes most U.S. trained specialists. The issue is a terminology mismatch. The College of Physicians and Surgeons of Ontario issues what is called a restricted certificate, even though it allows full, independent, unsupervised practice with no time limit. The only restriction is that we must practice within our specialty, in my case, emergency medicine. Why would the provincial nominee program create a pathway for physicians that is effectively inaccessible to nearly all immigrant physicians? It's almost certainly unintentional, but it represents a significant and unnecessary barrier for physicians who simply want to live, work, and contribute permanently in Canada. This reflects a broader pattern across the country. Regulatory bodies, immigration programs, provincial ministries, and federal frameworks operate in silos. Their requirements do not align, and internationally trained physicians get stuck in the gaps. Until I obtain permanent residency, my legal status is tied to a single work site, preventing me from providing locum coverage elsewhere. Locums are an effective way to support rural and remote communities. Many physicians, including myself, enjoy providing part-time coverage in high-need areas. But delays in immigration status limit our flexibility, as does the lack of reciprocity between provincial licensing bodies. It's important to emphasize that the clinical differences between the U.S. and Canada are minimal. We follow the same science and evidence, and similar standards of care. Yet licensure pathways vary dramatically between provinces, and the process can be opaque even within a single province. Several of my colleagues in the U.S. are interested in practicing in Canada, but cannot obtain a clear answer about eligibility. By contrast, in the U.S., while licensing is state-based, the criteria are transparent. If you meet objective requirements and have no history of misconduct, you know you will qualify before you invest extensive time and money into the process of applying. Given the rigorous standards of U.S. medical training and board certification, there's no reason Canadian provinces should not implement reciprocal or streamlined licensing for most specialties. For all of these reasons, I strongly support national licensure standards and a more coherent, streamlined pathway to permanent residency for internationally trained physicians, particularly those from equivalent training systems like the United States.
Very much. I now go to our next witness, Dr. Marie Dagenais, Executive Director and Registrar of the National Dental Examining Board of Canada.
Good afternoon.
I'm sorry, Madame Dagenet. Is it Dagenet or Dagenet?
Dagenet.
Dagenet. Good, thank you.
Good afternoon, and thank you, Madam Chair and members of the committee, for the opportunity to appear. Mon nom est Marie Dagenet. Je suis dentiste et la directrice générale du BNED.
I'm a dentist and executive director and registrar.
To establish and maintain a national standard for the practice of dentistry in Canada. The NDB is a not-for-profit organization supported by examination fees. All dentists, regardless of citizenship or country of education, are required to successfully complete our examination prior to licensure. The dental profession in Canada maintains reciprocal agreements with the United States, Australia, Ireland, and New Zealand. These agreements recognize the equivalency of dental education and facilitate licensure for graduates from those jurisdictions. However, internationally trained dentists from countries without such reciprocal agreements must demonstrate equivalency through one of two routes: completion of a 2-3-year university bridging program or completion of the NDB equivalency process, a structured assessment pathway. Global dental education varies widely in curriculum, clinical exposure, and assessment standards. Since the establishment of our equivalency process in 2011, over 12,000 ITDs have taken at least one of our examinations, but only 25% have completed all the examination and achieved certification. The success rate for our equivalency process varies between 33 and 93% between countries and 35 and 98% between universities. The examination administered by the NDB are essential safeguards to ensure public protection. Dentistry is a profession in which practitioners often work independently, alone, and without supervision. Therefore, a standardized and independent assessment of competence is critical. Canada is facing significant health human resource challenges, and this includes dentists. Although currently the number of dentists appears sufficient, there is a problem in terms of distribution with shortages in rural areas. Effective workforce planning is also necessary to support the CDCP that funds oral health care for low-income residents. Enrollment in Canadian dental program has remained unchanged for a decade, producing fewer than 600 graduates, including ITDs enrolled in bridging programs. ESDC projects dentistry is at a strong risk of shortages between 2024 and 2033. ESDC further indicates that a substantial increase in school leavers would be needed to prevent a shortage. An important government initiative towards addressing the health human resource challenges has been the prioritization of health-related occupation through the express entry system. While this approach appropriately seeks to strengthen Canada's health workforce, the inclusion of dentistry in invitation for healthcare professionals may unintentionally create unrealistic expectations among immigrants regarding their ability to obtain licensure in Canada. Prioritizing immigration candidates based on an academic credential in dentistry offers limited practical benefit in addressing Canada's oral health workforce needs. Health Canada's ethical framework for recruiting and retaining IEHPs emphasizes the need to avoid increasing the number of underutilized IEHPs and to support those already in Canada. In alignment with this principle, the NDB recommends that the federal government remove dentistry from the healthcare occupations included in dedicated immigration invitation and prioritize permanent residency pathways. The NDB also recommends collaboration between governments, regulators, and academic institutions to expand seats in accredited dental program for both domestic and ITDs to
46 seconds.
To increase the support of new dentists and help meet projection population needs. Finally, the NDB recommends a plan is developed to address the distribution issue through collaboration between the government, provincial regulators, and academic institutions. Merci beaucoup.
See? Thank you very much, Madame Dagenet, Dr. Dagenet. I'd like to now go to Dr. Meredith Irwin, who is pediatrician-in-chief of Sick Kids Hospital.
You,
Dr. Irwin. Thank you.
Thank you. Hello, bonjour. Honorable members of the Standing Committee on Health, it's an absolute privilege to provide testimony today on behalf of the Pediatric Chairs of Canada, or PCC. As you've heard, I'm the Pediatrician-in-Chief and also the Chair of Pediatrics at the University of Toronto and at Hospital for Sick Children. PCC is a national network of our academic child health leaders. We are dedicated to strengthening the future of pediatrics by working together to advance education, research, and the excellent care of our children, youth, and families. We also oversee the training of the next generation of specialized expert pediatric physicians across Canada. PCC and Children's Healthcare Canada, our sister organization, have been advocating to put children back at the center of policy making. Investing in children's health yields measurable social and economic returns. As you know, Canada's children have a right to health care. Right now, our collective ability to deliver this care in a timely way to children and youth increasingly depends on the strength of its highly specialized pediatric workforce. Today, that workforce is at risk. Across the country, pediatricians and subspecialists whose expertise is essential when children require preventative care, specialized treatments, or coordinated diagnostic and management of complex conditions are in very short supply. Importantly, pediatric subspecialists in areas such as cardiology, oncology, and neurology are not interchangeable with those who care for adults and are significantly fewer in number. There are more than 8 million children currently living in Canada, and this number will increase by 24% over the next 50 years. Yet across many jurisdictions, children now wait longer than adults for essential care, not because their needs are less urgent, but because our workforce is too small, aging, and increasingly stretched to meet the needs of an increasingly complex population of children. To better understand the scope, PCC in 2024 conducted a national data collection focused on pediatric subspecialty physicians, the workforce, and the trainees who are currently preparing to enter these fields. Our findings showed that shortages are causing delays in access to essential care, jeopardizing the short and long-term outcomes of our children. Fewer trainees are choosing pediatrics, resulting in a shrinking workforce, attempting to serve a growing, increasingly complex pediatric population. As you've heard, there are insufficient provincial residency spots to train a sufficient number of Canadian pediatric subspecialists to meet the current demand. And finally, and importantly, there are delays in hiring internationally trained pediatric subspecialists, including Canadians trained abroad. This threatens service delivery, teaching, capacity building, as well as research and innovation. Today, highly trained pediatric subspecialists, many urgently needed to maintain services, face unnecessary delays in immigration, protracted licensing timelines, and systemic obstacles, preventing them from joining the workforce in a timely manner. These barriers are not just administrative, they translate into longer wait times for children, and increased pressures on our hospitals, closure of programs, and lost opportunities. The PCC would like to submit the following recommendations to committee. We suggest streamlining immigration processes such as paperwork, work for authorizations for work permits and visas, creating faster, clearer pathways for permanent residency for pediatric specialists and other subspecialists. We feel we need to prioritize pediatric subspecialists in existing immigration streams, such as express entry. We suggest harmonizing and coordinating licensure requirements across provinces and territories to reduce variability, as well as developing national standards for recognizing training from countries with similar standards, as well as, and finally, creating and expediting consistent licensure. Thank you. We would support federal and provincial initiatives, including encouraging collaboration with the immigration groups that control that, as well as the provincial ministries of health and medical regulatory authorities. And we need to ensure that the pediatric workforce is counted as part of the broader HHR strategies that our government is putting important focus on, especially subspecialist care. And I want to highlight this is not just about physicians, it's about other specialty health providers that provide expertise care, such as nurses, psychologists, and others for children. So in conclusion, addressing pediatric workforce requires a coordinated national level action. PCC believes the federal government has a critical role to play to strengthen this pediatric workforce, both strengthening our domestic training pathways while also modernizing immigration,
13 seconds,
credentialing, and our way to get physicians here now. I look forward to answering any questions and providing examples if they would be helpful. Thank
very
you.
much. I'm going to go to the question and answer session. It begins with a 6-minute session, and that 6 minutes includes questions and answers, and I will be giving you the call out for 1 minute and 30 seconds so that you can all wrap it up, because I will not be allowing people to go over time because we have a time limit on a meeting in a committee meeting. Thank you. So beginning with the questions and answers, I go to the Conservatives. Ms. Conans for 6 minutes, please.
Thank you, Chair. Through the Chair. My first questions are for Dr. Irwin. Thank you for coming in today. Really informative and also disturbing in a lot of ways. So, Dr. Irwin, the pediatric unit at the Kelowna Hospital in my region was forced to close for several months amid a doctor shortage. While it has since reopened, I don't believe it's open to full capacity at this point. I'd like to ask, how common is it for a pediatric health care to be suddenly unavailable to a community the size of Kelowna, over 200,000 or nearly 200,000, I think it is now, but also it services the entire interior of BC, basically. It does for pediatrics. How common is that?
I think probably like many specialties, in pediatrics, the numbers are often fewer than they would be to serve a similar size population of adult caregivers or adult specialists. And I don't know the exact numbers in your writing, but I would suspect that the total number of physicians available at that hospital to provide pediatric services may have been under some strain, and perhaps it got to a critical number where there were not enough doctors to provide possibly safe health care. I don't know the details.
Is that common? Is that a common thing to happen throughout the country?
I think it can be. I can give you some examples from Ontario or from some of the groups that I'm more aware of. I'll give you a very different example. I'm a pediatric oncologist, so I care for children with cancer.
Thank you.
We in Toronto provide bone marrow transplants for children essentially east of Ottawa, from Ottawa and eastward. We only have 5 physicians, and that took a lot of work to recruit them to provide bone marrow transplants.
Okay. So
if any of those physicians leave, we will not be able to do what we can do. And if more than 2 left, we may have to. We would potentially have to close the program.
And have you closed then?
We have not needed to, but 4 out of
close.
those 5 are internationally trained physicians. We were not able to identify Canadians.
So what risks in care are possible to our children if a hospital lacks a pediatric unit? So if someone says to me, oh, well, they'll just go to another unit. Tell me what the risks are.
That's a really important question. As I alluded to, we are not the same. We train very differently in pediatrics. We do 4 years of training after medical school graduation in pediatrics, and then our subspecialties. So in oncology, that's another 3 years of hematology and oncology. We take care of different conditions, whether that be in kidney, heart, etc. And so physicians would not have the same expertise.
So
Exactly.
do you predict that at some point there's going to be pediatric units closing permanently? And would you say that we may come up with an excuse, or administration might come up with an excuse like, well, it'll be covered in other areas, but of course you don't believe that, and it doesn't sound like it's possible.
I do not believe that would be safe and high quality care for our children.
But you see that coming down the road.
I see it being a risk, especially when we have a strained workforce. There are so again, there's multiple specialties. There's general pediatrics, which is probably a big part of the population you're speaking about, but there's also many specialties under strain. We know that cardiologists who take care of our youngest children, pediatric cardiologists, more than half of our current practicing across the country are over 50, and over 20% are over 60.
Okay.
So that tells you something about that workforce.
It's a very dangerous situation. Is pediatric medicine that's taught in schools in Australia, America, or the United Kingdom, let's say, is it comparable to medicine that's taught in Canadian medical schools, and so would be interchangeable in that we could receive doctors from those countries and they should be able to fit right in with our pediatric requirements?
I believe so. Dr. McPherson spoke about that.
Yes.
I am also, you may have seen in my biography, I am a Harvard-trained physician. I did my medical school at Harvard. I did my residency at Boston Children's and Dana-Farber.
Okay, then it's very...
I believe it is incredibly similar, and we have standards that we follow, and
Of course you do, and
I
I'm
think
sure.
we would Yeah.
Thank you so much.
Sure. Thank you.
Dr. McPherson, it sounds as if, thank you for your opening statements. You said Canada licensing is burdensome, disorganized, and inconsistent. That's pretty clear what you feel about it and what we've been hearing from other witnesses. It sounds to me like Americans want to leave, want to work here. But would you say that Canada is getting a bad reputation in the United States or throughout the world, possibly? That after a while, we're going to get less and less people actually wanting to even try to make the leap to come to Canada, which we need so badly. We need those doctors so badly.
I wouldn't go so far as to say that Canada is getting a bad reputation. I think everyone understands that bureaucracy comes with paperwork and
But you said Canada has a lot more than you.
32 seconds.
But there certainly is frustration with the process, and there's a very large online community of U.S. physicians that explore the options of practicing abroad.
One more quick question. Sorry, we only have a few seconds. Sorry to interrupt you. So British Columbia instituted a campaign to try to recruit more U.S. physicians, but do you know any of your colleagues who are looking to move to British Columbia? Is that working? Because you originally were going to move there, right? And is it working, do you feel?
Yeah, I actually have a couple of colleagues who have moved to British Columbia
and
this
are they
year.
actually working?
Thank
Okay,
you.
great
The
to hear.
time is up.
Thank you.
Thank you. Mr. Ailson, for 6 minutes, please.
Thank you, Chair. Thank you all for coming. This is all very useful information. Dr. McPherson, you talked about a lot of the barriers for immigrants coming in with these trainee programs. Now, I just want to you said that this is with the foreign trainee programs. Is this the federal, or sorry, the provincial nominee program? So is this spots determined by the provinces?
Yeah, so I'm referencing provincial nomination. So those are unique to each province, and they're basically pathways to express entry to facilitate getting permanent residency. And then there's specific pathways for physicians.
Mm-hmm. Okay, thank you. Dr. Dagenais, you talked about the different programs for different graduates to different countries. You talked about the bridging program. Now, is each bridging program specific to each province, or is this a federal initiative? Or is it a unified federal initiative?
No, the bridging program depends on the university. They're organized by the university, and not all Canadian faculties of dentistry have them.
All right, thank you. Now, I'm more familiar with medical licensing. Are dental licenses, is a dental license provincial or is it federal?
A dental license is provincial.
All right. Is there portability or flexibility between provinces with a license to practice dentistry?
There is. Our exam, our certification exam is required by all provinces, and then you're portable between the provinces.
Okay. If I'm practicing in Ontario, if I'm a dentist practicing in Ontario, and I want to practice in Manitoba, even for a locum, I want to go and, there's a dental clinic that needs coverage for a week. If I wanted to go from Ontario to Manitoba, would I have to apply for a Manitoba license to do that? Or would my credentials be recognized to allow me to just simply go and work?
You will have to apply for a license in Manitoba. Manitoba may have an additional requirement, something like an ethics course. I'm not sure about Manitoba, but it's actually fairly simple to move from provinces to provinces.
Okay, thank you. Yeah, I asked this because I find myself in a similar position. You know, my skills are very portable. I have a Royal College in Emergency Medicine that's recognized in, you know, any province. Kenora, Ontario is a 2-hour drive west of me. When they are short, I could hop across the border on a week off and do some shifts. However, I'd have to go through all the steps to apply for an Ontario license to practice. So would you agree that it would be, Canadians would be better served if there was some cooperation, that provinces would recognize each other's licenses?
I would agree with you.
All right, thank you. Dr. Irwin, thank you for what you do. I work in emergency medicine. I've worked in a lot of departments that, that will see children and adults. And, given the low volume of critically ill children, you can imagine that when a critically ill child rolls in, to those of us who don't see too many children, it is, to say the least, anxiety provoking. So I appreciate what you do, because as you're right, they're not just small adults. They have very, very unique healthcare needs. So when you were talking about the different countries that, the pediatric training is considered equivalent, again, is this the provinces that do that, or is it the federal government?
Currently, the licensing, so the CPSO, which would be our licensing authority in Ontario, would make that determination. So there's currently a different pathway that has just changed for U.S. trainees versus others. And then it depends on which parts of your training you did where. But I would really welcome some collaboration and similarity across provinces, especially in pediatrics, where we would love to help where possible across provinces when there are critical shortages like you heard about, and in some of the provinces where they can't recruit specialists at all in certain areas.
4 seconds.
Thank you. Well, then that's my time. Thank you very much.
I now, Madame LaRouche, pour 6 minutes.
Ms. LaRouche, you have 6 minutes, please. Thank you very much, Madam Chair. Ms. Dagenet, you mentioned it, and we heard from a dentist at a different meeting also who was explaining the pressure of the insurance system on providing services. And I heard this week, actually, you talked about rural areas in your opening remarks. I got a comment this week saying that in Sept-Îles, where they live, there is already limited access to dental services, and the new program, the CDCP, is not adapted to the needs of the community, and the clinics are inundated with patients, and there is not enough of them, and they are far away. But I can almost never get an appointment. Perhaps I can get appointments over many years. They are far away. They cost a lot, and they're incompatible with my workplace schedule and, for example, my family obligations, and therefore I can't have basic ongoing care. So you talked about the needs in immigration so that we can fill some of the gaps in our dental health system. So in terms of this insurance, do you think the government should have used or should have looked at the issue of practitioners more and the available practitioners more before putting the people in place? Because the program was announced, but there's not enough people to provide service. One of my recommendations is that there needs to be cooperation between orders of government and also professional orders, universities, organizations such as ours. currently we need a plan, and currently we are seeing people go through exams. There's a lot of need, but what happens to those people once they pass the exams? Where do they establish themselves? Where do they practice? There's no plan. So we need a plan to ensure that rural areas have access to dentists, and that there's also other areas, for example, those who are disabled or in more higher need areas. We need to make sure everybody can get access adequate care. During your opening remarks, you also talked about those who need to pass the exam. It can take 2 to 3 years to get their skills updated. Is that what you were saying? The bridging programs? Yeah, the bridging programs for foreign dentists in Canadian universities last 2 to 3 years right now. Yes, and during that time, are you hearing from people saying that it's a little bit difficult because they're in a gray area? They don't necessarily have access to the same resources as others. For example, if they have any difficulties during those 2-3 years, are there any stable measures that could be put in place to support professionals who are trying to get their credentials up to speed so that they can have their diplomas recognized? Well, what we would need is more spots in bridging programs. Currently, actually in 2024, there were 61 spots, but at our organization, at NDBC, we get 1,500 to 1,700 requests from dentists from overseas or elsewhere trying to access our program. So that's a lot of people who cannot access our programs, and their second option is to go through the credentials equivalency program that we offer. But the rate of success at those exams is quite low, and it depends quite a bit. I talked about the various rates going from 30 to 70%, and there are some people who don't get in, and over half of candidates need to retake exams. What we would really need is more spots to support foreign dentists, because we need them. But we need to be able to provide support so that they can be successful and contribute to the profession. Thank you very much. Dr. Irwin, to your knowledge, do you get people who are funded, whose visas are funded by foreign countries, and do these students meet the needs because many of them return to their countries?
Question. Yes. So I am part of the University of Toronto, and you previously heard from Dr. Houston. So we have a small subset of that 459 visa trainees she mentioned. You're correct. They do return to their country, but they do not take spots that are available for our Canadian graduates. And they, as you also heard, are very critical to providing this workforce that is strained right now and expanding our workforce. But they definitely do not take the inadequate number of spots that we have currently for pediatric specialty training.
Thank you very much. We're going to go to the second round, and that is a 5-minute round. And so I begin with the Conservatives. 5 minutes, please, Mr. Bailey.
Thank you, Chair. Through the Chair, Dr. Irwin, how many pediatric spots are there across Canada? It's under 10, is it?
So that's part of our initiative where we collected the data. So if we look at provincially funded, so publicly funded spots, on average, there's around 65 a year for the subspecialties, and a larger number, I think I'll have to get you the exact number, but it's at least double that number for general pediatrics. So first you must do general pediatrics for 4 years, and then the subspecialties. So that 65 is for that latter part of training.
Okay. Now, I'm going to ask this about the special extra spots. Do you know how many, and just speak to Ontario, do you know how many extra spots there are for pediatrics in that extra group through the University of Toronto?
So are you talking about the visa specifically?
Right on, yeah.
Yeah, so I do know for general pediatrics.
Yeah.
For general pediatrics, we have about 4. And it, again, does not take away from the other 20 to 25.
I get
a
that.
year.
Now, of those 4, have you ever had a female from
Yes.
Saudi Arabia?
Yes.
You have?
Yes.
And how did you deal with the language barrier? Did that work itself out?
So all of our trainees, not just the visa trainees, all of our trainees who are not Canadian medical graduates take part in a, I'll call it a probationary type of process we have for the first several months. And they are not only judged on their medical competency, but also their language competency
Thank
as
you so
part
much.
of that.
I'd like to share my time, Madam Chair, with Dan Mazer. Thank you.
Mr. Mazer, you have 3 minutes and 12 seconds.
Thank you, Chair, and I'd like to move the following motion. Given that the Chair abruptly suspended the meeting before completing 1 hour of testimony as agreed by the committee summons Dr. Patricia Houston, Vice Dean of Medical Education at University of Toronto, to appear within 1 week of this motion for 1 hour of testimony as part of the study on the impact of immigration policy in healthcare.
Now, there's a motion on the floor. Ms. Sidhu?
Madam Chair, I just want to let everyone know there's a technical difficulty, like 2 or 3 times happened. It's not anybody's fault. It was technical difficulty. And then second panel was waiting for that. Everyone has a question for the second panel. It's not anybody's fault. It's technical difficulty.
Thank you. I've got Ms. Conant.
Yes, I support this motion, and I would like it to go to a vote. I know for myself, I especially did not get to ask her any questions, the representative from the University of Toronto, and I felt that all of us here were really being educated about the programs that U of T offers, in particular for Saudi Arabian students. And I think we were getting to the core of what might be an issue in our medical system here, where we're excluding Canadians and bringing on people from other countries who are not staying here to work. And I don't know about everyone else around this table, but the people in my riding, in my area, are desperate for these doctors. We can't have people come and train here and then leave the country. If there's room for somebody to be here and train, then there must be room for a Canadian or somebody from another country to train here and then stay here. So they're taking up a space. I'd like to hear more about it, and so I support this motion.
Mr. Strauss? To the motion, please.
Thank you, Chair. It's a really important issue. The motion that we previously agreed to was that we would do 1 hour of questions with her. We debated that motion at length. From my point of view, there already procedurally is a motion to that effect. We only got 50 minutes with her. I think the next time she appears, it could be by Zoom. There's no reason that it needs to put her out and fly her back up to Ottawa. But ultimately, this committee's already agreed. We had 1 hour of questioning with her. We didn't get it because of technical difficulties. But we did have resources to continue. So,
just to clarify, we were 11 minutes short in that hour. So perhaps you would like her to come for 11 minutes?
I think if she is going to the hassle of reappearing, then 11 minutes seems not.
You just suggested a Zoom meeting.
Sure, I think that would be reasonable, depending on her schedule. But she was giving very interesting answers. I think it's a fundamental issue with our medical education system if we're training up to 20% of doctors at these institutions to not serve Canadians using Canadian public resources. So yeah, I support the motion. Thanks.
Thank you, Mr. Strauss.
Can we suspend for a moment, please?
Would you like to suspend, Ms. Chi?
Thank you.
We suspend. And I let it be known that as a courtesy, I'm allowing the Conservative member to have 5 minutes with the witnesses. Mr. Strauss.
Thank you, Chair. So my questions today are for Dr. McPherson. Dr. McPherson, thank you so much for coming today. It means a lot on behalf of the people of Kitchener. Thank you for coming to serve our community. And beyond that, thank you for coming to committee today, because you're not just serving Kitchener now, you're serving the whole country of Canada. So we're really pleased and proud to have you here. I'd like to ask some questions at a high degree of granularity, because I think individual cases help us to understand what is actually going on with immigration for healthcare professionals. If I ask you any questions that are prying or you don't feel comfortable answering, just please let me know. I don't feel compelled to answer anything. We spoke a little bit before the meeting. By your lights, now you've practiced in both countries. You've practiced all around the United States, as you told me. Is there any reason ER doctors in general in the United States wouldn't be able to practice in Canada tomorrow?
Not that I'm aware of. I haven't found any really significant differences in the practice patterns that would prevent an American physician from practicing in Canada.
Fantastic. And overall, when you decided to come to Ontario, what barriers in terms of getting your license recognized did you meet?
I actually found the CPSO process for licensing to be fairly straightforward, just quite long. But I would say that compared to kind of the confusing process of British Columbia, Ontario's CPSO compares favorably.
I'm pleased to hear that. When you say long, how long do you mean?
It took me a few months to get the documents together. A lot of that includes getting official copies of transcripts from medical schools, which have to be mailed directly to the CPSO, and those are sort of the rate-limiting steps. If you are really dedicated, you can get it done within 2 or 3 months.
I see. So, I mean, I would say, I won't ask your opinion on this, but I would say I think that if you hold a license in Oregon, it's probably the case that you passed all your med school courses. And it's a little bit strange to me that they would insist on verifying those documents in particular. You spoke a little bit about the provincial nominee program and how that was giving you a hard time because of some terminology that I think pretty obviously needs to be changed. But may I ask, which immigration program are you currently here on and working under?
So I'm currently here on a temporary work permit, which will expire after 3 years.
I see. And then beyond the provincial nominee program that you're speaking about, are there any other federal immigration programs that you have evaluated or considered or engaged that could take you on the path to permanent residency?
I'm not aware of any other pathway that would be viable for me. I am trying to improve my French to get some additional points for my application.
Tell me a little bit more about that. How would improving your French improve your ability to buy a home in Kitchener, Ontario?
So if I can demonstrate a certain level of French, then I can potentially apply for express entry as a French-speaking skilled worker, which is an alternative pathway.
I see. And so if you were to be evaluated and meet criteria to be a French-speaking skilled worker, you would have an easier time achieving permanent residency to work in Kitchener, Ontario as a emergency room physician?
Yeah, I mean, essentially it's a completely different pathway, which I don't think has any specific bearing on being a physician. It's really just any skilled professional who is fluent in French can qualify for an alternative pathway to express entry.
All right.
1 minute.
I'm honestly a bit flabbergasted by this. Could you tell me which languages other than English you encounter in the emergency room in Kitchener, Ontario, say by frequency?
I think quite a few of my patients are Indian, and so speaking various language from India. I've had quite a few patients who speak Mandarin, Arabic. I don't think I've had any patients who speak French and do not speak English.
I see. It seems to me, I won't ask you to speak to this as you're going through the immigration process, but it seems to me that this could be rationalized in part. And then, so Could you speak a little bit about if you continue to have difficulty achieving permanent residence status, either through the PNP program or any other program, what hardships does this cause you? Does it put you at risk of going back?
I mean, the short-term issue is that there's a 25% foreign investor tax on purchasing a home. So I'm living in a rental house with my husband and children, which is not a position I've been in quite some time. It's not ideal. We would love
Thank
to
you.
be
We've
able-
gone 21 seconds over time, Mr. Strauss.
Thank you very much.
I wish to thank the witnesses for being here, and I wish to thank them for giving their time and their expertise to the answers. I also want to thank the committee for being generous enough to give the Conservatives an extra 5 minutes time for questioning because no one else got that. So thank you for that courtesy. And I now adjourn the meeting.
Chair?
Yes, Mr. New?
I just moved to adjourn the meeting.
Yes, meeting's adjourned.
Chair, I object.